Welcome to the deep dive. Today we're going into, well, a pretty significant area of health that you might not think about every day. Thoracic and Thoracoabdominal Aortic Aneurysms. We usually call them TAAAs. So if you want to get a quick but, solid understanding of an important medical topic, you're definitely in the right place.
Exactly. Yeah, we're looking at TAAs. Basically, they're these localized weak spots, bulges, in the wall of the aorta.
The body's main artery.
That's the one,
Yeah.
specifically in the chest and the upper abdomen parts. And they can become, well, quite serious if they aren't understood and managed properly.
And we're basing this discussion on a detailed medical chapter, kind of our source material for today. Think of us as your guides, pulling out the really need-to-know info.
Making sense of the complexities.
Yeah. We'll look at what causes them, who gets them, how doctors find them, and the current ways to manage them, both medically and surgically.
And it's probably good to clarify our focus. Aortic aneurysms can happen in different spots along the aorta, like the part leaving the heart, the ascending aorta, or the arch.
Right.
But today we're specifically zoning in on the ones in the descending thoracic aorta, that's the part going down through the chest, and the thoracoabdominal aorta.
Okay, so that's the stretch from what, near the shoulder?
Pretty much from the left subclavian artery down to where the aorta splits to go to the legs. So not the ascending or arch types today.
Got it. It's interesting. When you think about big health risks, heart attacks, strokes come to mind first.
Sure.
But aortic disease, our source actually highlights it as a surprisingly significant cause of death in the U.S.
It is. It often flies under the radar.
So our mission today is clear. We're bringing you the crucial details, the interesting bits about TAAs, without getting totally lost in the medical jargon. Okay, let's start with the basics. What exactly is an aneurysm, specifically a TAAA?
Okay, so at its core, an aneurysm is just a dilation, a widening of a blood vessel. For a TAAA, it means the aorta in the chest or upper abdomen has ballooned out significantly.
How significant?
The standard definition is at least 1.5 times the normal diameter for that specific section of the aorta.
Right, 1.5 times.
And like we said, location is key. We're focusing on that descending thoracic and thoracoabdominal section from below the left subclavian artery down to the aortic bifurcation where it splits.
Okay, and what does a healthy aorta look like in that area, just briefly?
Well, the aorta isn't just one uniform tube. It has segments. The root, ascending, arch, and then the descending thoracic part we're talking about. And like other arteries, its wall has 3 layers: intima inside, media in the middle, adventitia outside. An interesting point is that the aorta naturally tapers a bit, gets slightly narrower as it goes down from the heart towards the abdomen.
So there's a normal range of sizes that changes along its length. How do doctors know when that widening becomes an actual problem, an aneurysm?
Yeah, defining normal versus pathological size is critical. Because the diameter, how wide it is, that's the single strongest predictor of whether it might rupture.
Okay.
Our source mentions that the average TAAA is about 6.1 centimeters wide when it ruptures, but normal size isn't one number, it varies.
Right, you said it tapers.
Exactly. It depends on the aortic segment. Gender women tend to be a bit smaller even after adjusting.
How much smaller?
Usually about 2 to 3 millimeters, typically. Age is a factor too, and body surface area. Interestingly, body surface area is actually a better predictor than just height or weight alone.
That's fascinating. So it's really tailored to the individual. What about the shape? Are all these bulges the same?
No, good question. There are 2 main shapes, fusiform and saccular. Fusiform is the most common for TAAs. Think of it like the aorta extending pretty evenly all the way around its circumference.
Like a sausage shape?
Sort of, yeah. Uniform widening. Saccular is different. It's more like a bubble or pouch sticking out on one side, an eccentric bulge. And while most TAAs are fusiform, the source does point out that saccular ones might be a bit more concerning. They might need repair at a smaller size because they could have a higher risk of rupture.
Okay, that gives us a really good picture of what a TAAA is. So who tends to get these? Is there a typical patient profile?
Well, TAAs are primarily seen in older adults. The average age when they're diagnosed is around 65, and there's a definite gender difference. Men are about 1.7 times more likely to get a TAAA than women.
1.7 to 1. That's noticeable. Different from other aneurysms?
It is, especially compared to abdominal aortic aneurysms, the TAAAs, which are lower down. TAAAs tend to affect an even older group, and the male-to-female ratio is much higher, maybe closer to 6 to 1.
Wow, 6 to 1 for AAAs. Why the difference?
That's a good question, and it's still something researchers are looking into. The reasons for that difference in gender prevalence aren't fully understood.
Okay. What about family history? Are there genetic links we should know about?
Oh, definitely. There's a clear genetic component. The source says over 20% of TAAA patients have a first-degree relative, parent, sibling, child who also has aneurysm disease.
1 in 5.
Yeah. And there's a specific condition called familial thoracic aortic aneurysm, TAD. It's usually inherited in an autosomal dominant way,
Mm.
meaning if one parent has the gene, there's roughly a 50% chance of passing it on. But how it shows up can vary a lot, even within the same family. Researchers have found 37 genes linked to it so far, explaining maybe 30% of these familial cases.
Okay.
And of course, you can't really talk about genetic aortic issues without mentioning Marfan syndrome. That's really the most well-known genetic disorder associated with aorta problems.
Right, Marfan syndrome. So family history is a big red flag. What about lifestyle or other common health issues? What increases the risk?
A lot of the risk factors overlap with AAAs, actually. High blood pressure, definitely, especially if the bottom number, the diastolic pressure, is consistently over 100.
Okay.
Smoking is a major one, and having atherosclerosis, plaque buildup in other arteries.
Makes sense.
And another important factor, up to 20% of TAAAs actually develop as a long-term consequence of a chronic aortic dissection.
Which is a tear in the aorta wall itself.
Exactly. A previous tear can weaken the wall over time, leading to an aneurysm later on.
Are there any less common causes, things people might not expect?
Yes, a few. Certain systemic autoimmune diseases, like Takayasu arteritis, can cause inflammation that weakens the aorta.
Uh-huh.
Some congenital conditions, like aortic coarctation and narrowing someone's born with, can be linked. And though it's rare, infections can sometimes lead to what are called mycotic aneurysms.
Okay, so it's really a mix. Age, genes, lifestyle, sometimes previous aortic events or other conditions. Now, you said earlier they often fly under the radar. Does that mean they usually don't cause symptoms?
That's a really critical point. Yes, the vast majority of people with TAAs are completely asymptomatic. They feel fine.
So how are they found then?
Often it's purely incidental. Someone gets a chest x-ray or a CT scan for something totally unrelated, maybe pneumonia or back pain or kidney stones, and the scan happens to show this bulge in the aorta. It's often a surprise finding.
A silent threat then. If someone has one and doesn't know, what's the likely outcome if it just goes untreated?
Unfortunately, the natural history, the usual course of an untreated TAA, is quite poor. The source mentions a mean survival time of less than 3 years.
Less than 3 years. Wow.
Yeah, and rupture, the aneurysm bursting, is a major kind of death.
That's incredibly serious. Does it just grow steadily until it bursts?
The growth can be variable. It's not always predictable, but there's a general trend similar to AAAs that the bigger the aneurysm gets, the faster it tends to grow.
Ah, so growth accelerates.
It seems to, yes. For instance, aneurysms bigger than, say, 5 centimeters might grow around 0.3 to 0.8 centimeters per year. Smaller ones, less than 5 centimeters, might grow more slowly, maybe 0.17 to 0.22 centimeters per year. And another interesting point is that the lower parts of the aorta, the distal segments, seem to grow faster than the parts higher up in the chest.
So size is clearly critical, both for growth rate and the risk. What do the survival numbers look like based on size?
The data really bears that out. The source states that for someone with a 6.0 centimeter TAAA, the 5-year survival rate is only about 54%.
Just over half.
Right. With an annual risk of rupture somewhere between, say, 3.7% and 5.9%, and an annual risk of death around 12%.
And if it's bigger than that?
If it gets larger, say over 6.5 centimeters, those risks jump significantly. The annual rupture risk goes over 9%, and the risk of death climbs above 18% per year. The median survival for untreated TAAAs overall is only about 3.3 years.
Those are really sobering statistics. It hammers home why detection is so important.
Absolutely.
Besides the actual size, are there other things that make a rupture more likely?
Yes. While the maximum diameter is the single most reliable predictor of rupture or dissection.
Dissection being the tear again.
Right, the tear in the wall. Other factors include being older, having COPD, chronic obstructive pulmonary disease,
Okay.
experiencing persistent, sort of uncharacteristic pain, which might signal instability. The diameter of both the descending thoracic and the abdominal aorta matter, and having had a previous aortic dissection is a big one. Those post-dissection aneurysms tend to be more fragile and can rupture at smaller sizes than the typical degenerative ones.
Right, that makes sense.
The source also gives some estimated annual event rates rupture or dissection based on size. Less than 50 millimeters, the risk is under 1%. Between 50 and 60 millimeters, it jumps to maybe 2.7% to 8.1%.
A big leap.
Yeah. And over 60 millimeters, it's potentially very high, cited as 37.5% to 62.5% in some studies, though these ranges can vary.
Wow. Okay, so it's a mix of size and the patient's overall health profile that determines the risk. So how do doctors actually see these things? How are TAAs diagnosed?
Imaging. Imaging is absolutely fundamental. Without it, these often remain hidden until something catastrophic happens.
What about just a standard chest x-ray? Would that show anything?
It might give some hints. You might see calcification in the aortic wall, or the aorta might look generally enlarged. Maybe the space in the middle of the chest, the mediastinum, looks wide, or the aortic knob looks prominent. It can sometimes show the windpipe being pushed aside. But honestly, while it's often done routinely before surgery, it's not very reliable for diagnosis. Its sensitivity, its ability to pick up the disease when it's there is pretty low, maybe 64–71% based on some signs. Its specificity, correctly saying things are normal when they are, is better, around 86%.
So an x-ray might raise suspicion, but you need something more definitive. What's usually next?
Computed tomography, the CT scan, that's really considered the gold standard now for looking at the aorta if you suspect a TAAA.
Gold standard, okay. Why is it so good?
Modern CT scanners, especially the multi-detector ones, are incredibly accurate. Sensitivity and specificity are well over 95%. They give detailed cross-sectional images, like slices through the body, and these slices can be reconstructed by computers into amazing 3D images. This lets doctors measure the aneurysm precisely, see exactly how far it extends along the aorta, and check its relationship to nearby organs and blood vessels, like the ones going to the kidneys or intestines.
Very detailed.
Yeah, and it can also spot other things that might affect treatment choices. The main potential downside is the need for intravenous contrast dye, which can be risky for people with kidney problems.
The contrast dye. So what are the options if someone has poor kidney function?
In that case, magnetic resonance imaging, MRI, and its counterpart for blood vessels, MRA, magnetic resonance angiography, are good alternatives. They don't use the same kind of iodine-based contrast that can affect kidneys.
Okay.
MRA has also been used sometimes to map out the blood supply to the spinal cord before surgery, which is important for avoiding paralysis, a potential complication.
But a Millera must have some drawbacks too.
They do. Generally, the spatial resolution, the ability to see very fine details, isn't quite as sharp as CT. They're also not as good at showing blood clots or calcium deposits within the aneurysm wall. Plus, the scans usually take longer, they can be more expensive, and any metal implants in the patient's body, like pacemakers or artificial joints, can interfere with the images.
Right, the metal issue. What about older methods like putting a catheter right into the artery, arteriography?
Yeah, arteriography or angiography. That used to be more common. They thread a thin tube into an artery, inject dye, and take x-rays. But for just diagnosing a TAA initially, it's really been replaced by CT and MRI. It might still have a role in very specific situations, like getting that highly detailed map of the spinal cord blood supply before a complex open surgery, but for diagnosis. Not usually the first choice anymore.
Okay. And are there any blood tests, any biomarkers that can tell you if you have a TAA?
Not currently, no. There's no specific blood test that says, yes, you have a TAAA, or no, you don't. It's definitely an active area of research, though. Scientists are looking for specific proteins or other substances in the blood that might indicate aortic disease.
So maybe in the future.
Hopefully. But for now, routine blood tests are just done as part of the general health check before any potential surgery.
So advanced imaging, mainly CT or sometimes MRI, is really how these are found and evaluated. Once one is identified, what happens? Is surgery always the next step?
Not necessarily, no. Medical therapy is actually a really important part of managing TAAs.
Okay.
Especially for aneurysms that haven't reached the size where surgery is recommended yet, or for patients who might be too frail or have too many other health problems to be good candidates for a major operation.
And is this medical therapy specific to TAAs?
That's a good point. A lot of what we do medically is actually extrapolated, kind of borrowed from what we know works for other aortic conditions, like aneurysms higher up in the ascending aorta or aortic dissections. There hasn't been as much large-scale research focused only on medical therapy for TAAs specifically.
Okay, so what does this medical management typically involve?
The main goals are controlling risk factors. So strict blood pressure control is key. The target is usually 140 over 90 or even lower, like 130 over 80 if the person has diabetes or kidney disease.
Right.
Medications called beta blockers are very commonly used. Also, ACE inhibitors or ARBs, angiotensin receptor blockers. Statins for cholesterol and inflammation are important too. And absolutely critical, stopping smoking.
Let's break those down a bit. Beta blockers, we hear about those for heart conditions.
Yeah.
How do they help with an aneurysm?
The idea is that they reduce the force of the heart's contraction and also slow the heart rate. This lessens the stress on the aortic wall.
Makes sense.
They have shown benefits in slowing down aortic enlargement near the heart, particularly in patients with Marfan syndrome. The evidence for them slowing growth in typical degenerative TAAs is maybe less definitive.
Okay.
But beta blockers are excellent at preventing heart attacks, which is a big risk during and after surgery. So they're generally used or continued if a patient is already on them, especially around the time of any intervention.
Got it. What about ACE inhibitors and ARBs? How do they fit in?
There's growing evidence that something called oxidative stress is involved in how these degenerative TAAs develop. And the system that ACE inhibitors and ARBs target, the renin-angiotensin system, seems to play a role in that stress. Some studies, particularly with ARBs, suggest they might help by reducing harmful reactive oxygen species in the aorta wall, possibly by affecting a signaling pathway called TGF-beta.
Interesting.
The evidence seems strongest for ARBs and Marfan syndrome, but there's increasing support for using them in degenerative TAAs, too, to potentially slow things down.
And statins. You mentioned they're not just for cholesterol.
Right. Besides lowering cholesterol, statins have anti-inflammatory effects. There's some research suggesting a specific enzyme, NADH-NADPH oxidase, might be involved in TAA formation, and statins could potentially inhibit it.
Okay.
There's also some evidence from AAA studies that statins might slow AAA growth and maybe reduce degeneration in the ascending aorta. The results on whether they improve survival after TAAA repair have been a bit mixed, though, which might hint that the underlying processes in TAAs and AAAs aren't exactly the same.
And finally, smoking cessation. Seems obvious, but why is it so crucial here?
Because smoking is just bad news for aneurysms all around. It's a major risk factor for developing them in the first place.
Right.
And in people who smoke, TAAs tend to grow faster and they have a higher risk of rupturing. While we might lack a big clinical trial proving that quitting specifically slows thoracic aortic growth based on everything we know from AAA research and smoking's general damage to blood vessels.
This is a no-brainer.
Absolutely. It's a critical recommendation for anyone diagnosed with a TAAA.
Okay, so medical therapy is about managing risks and maybe slowing things down. But inevitably, for some people, that won't be enough. When does the conversation shift to more invasive treatment, like surgery?
That's the crucial decision point. It really comes down to balancing the risk of the aneurysm rupturing, which we know can be fatal, against the risks involved in the repair procedure itself, whether it's open surgery or the less invasive endovascular approach.
Endovascular being TEVAR.
Exactly. Thoracic endovascular aortic repair using stents delivered through catheters. The availability of TEVAR has definitely changed the calculation for many patients.
Are there clear size cutoffs? Like if it reaches X centimeters, you need surgery?
It's a bit less clear-cut for TAAs than it is for AAAs, partly because we just don't have the same volume of large long-term studies. Plus, TAAs themselves can vary a lot in how much of the aorta they involve.
Okay.
And you really have to consider the patient's overall body size. A 5.5 centimeter aneurysm might be relatively bigger in a smaller person.
Good point.
But as general guidelines, repair is often considered when the diameter gets somewhere between 5.2 and 5.6 centimeters, or when it's about twice the size of the healthy aorta right next to it. Some even suggest adjusting thresholds based on height.
Okay.
And certainly, once an aneurysm hits 6 centimeters or more, repair is usually strongly considered.
Are those hard and fast rules, or are there exceptions?
Definitely more like guidelines that need individualizing. For example, in patients with connective tissue disorders like Marfan or Loeys-Dietz syndrome, the threshold is often lower, maybe closer to 6.0 centimeters, sometimes even less.
Because their tissue is weaker.
Precisely. Also, a strong family history of someone having an aortic rupture or dissection might lead doctors to intervene at a smaller size.
Right.
The source mentions this idea of hinge points, sizes where the rupture risk seems to climb more steeply. One suggestion for the descending thoracic aorta is maybe around 7 centimeters. But, and this is a critical rupture, can absolutely happen at smaller sizes, especially, as we said, if there's been a dissection. Also, the type of TAA matters. Based on the Crawford classification, which describes how much aorta is involved, doctors might use slightly different thresholds. More extensive repairs have higher risks, so the threshold might be slightly higher for those.
Makes sense.
And one final really important point. If an aneurysm starts causing symptoms, like significant pain, that usually prompts consideration for repair regardless of the size. Symptoms suggest instability.
Okay, so it's a very nuanced decision. Size, patient factors, genetics, symptoms all play a role.
Yeah.
If the decision is made to go ahead with a repair, what happens next? What kind of workup is needed?
A really thorough preoperative assessment is essential. You want the patient in the best possible shape for the procedure, and you need to plan the intervention meticulously.
What does that involve?
It starts with a deep dive into their medical history, a comprehensive physical exam focusing particularly on their heart, lungs, and kidneys. And, of course, carefully reviewing all the imaging, the CTs or MRIs, to plan the exact surgical approach. Standard blood tests, an ECG for the heart, and a chest X-ray are also routine.
You highlighted heart, lungs, and kidneys. Why are they such a focus before TAAA repair?
Because complications involving these systems are major drivers of risk and poor outcomes after TAA surgery. Heart problems are common. Many of these patients are older and have underlying coronary artery disease. That's a leading cause of complications, even death, after open repair.
So heart tests are needed.
Often, yes. Maybe stress testing, sometimes even a coronary angiogram to look directly at the heart arteries. Lung function is also critical. A lot of patients have a smoking history or existing COPD.
Right.
This puts them at high risk for pneumonia or breathing difficulties after surgery. So pulmonary function tests, checking blood oxygen levels, those are often done. And kidney function is a huge predictor. Even mild kidney impairment significantly increases risk.
Okay.
So we check kidney function with blood tests like creatinine and GFR, sometimes imaging the kidneys too. And leading up to surgery, it's vital to keep the patient well hydrated and avoid any drugs that could potentially harm the kidneys.
What about just their overall fitness? How frail or strong they seem?
Absolutely. That functional status, their general ability to handle daily life, is a really important predictor of how they'll do. While patients needing TAA repair are often older and have other issues, studies show that age by itself shouldn't automatically disqualify someone from elective repair. Many patients, even older ones, can recover well and regain good functional ability afterward.
Good to know. Now, we've focused heavily on TAAs, but our source mentioned a couple of other related thoracic aorta issues briefly. Can you touch on those?
Sure. Yeah, the source briefly covers two others. One is an aberrant right subclavian artery.
Okay, what's that?
It's a common congenital variation, something someone's born with, where the artery to the right arm doesn't branch off where it normally does. It comes off later from the aortic arch and often passes behind the esophagus.
Does that cause problems?
Sometimes, as it gets older or if it enlarges, it can compress the esophagus, causing difficulty swallowing. It can also become aneurysmal itself or be associated with dissections or other aneurysms nearby. Treatment might involve a hybrid repair combining some open surgery with endovascular stenting.
Okay, and the other one?
The other is coarctation of the aorta. That's also congenital and narrowing of the aorta, usually just beyond the arch. If it's severe and isn't treated, it can lead to very high blood pressure, heart failure, and can be fatal. Treatment is either surgical repair or, increasingly, using balloons or stents endovascularly to widen the narrow segment. But sometimes people need further procedures later on if it narrows again or if an aneurysm forms at the repair site.
Okay, that's a helpful overview of those related conditions. So let's try and pull all this together. Thinking about TAAs, what are the absolute key takeaways for our listeners?
I think the main things are TAAs are serious but often silent conditions. They develop due to a complex mix of things: genetics, lifestyle, age, other health issues. Because they're often silent, early detection through imaging is absolutely vital. And once found, management needs to be careful and ongoing. That involves good medical therapy, controlling blood pressure, cholesterol, stopping smoking, and making timely decisions about intervention.
Intervention being surgery or TAAA.
Exactly. And that decision hinges on the aneurysm's size, how fast it's growing, the patient's overall health and risks, and whether it's causing any symptoms. Getting that balance right is key to improving outcomes and preventing that catastrophic rupture.
Absolutely. And hopefully, you listening now feel you have a much clearer, deeper understanding of TAAAs than maybe you did an hour ago,
Yeah, hopefully we've moved beyond just the surface level.
which leads to maybe a final thought to leave you with.
Okay.
Given that we seem to be seeing more thoracic aortic disease, maybe because our imaging is better, maybe because the population is aging, what does that mean for public health? Should we be thinking more about screening? How do we raise awareness about the risks?
That's a great question. It really points towards the future. What's the potential role for broader screening, especially in high-risk groups? How do we better educate people about risk factors like blood pressure and smoking in relation to aortic health? And of course, the ongoing research into even earlier detection and less invasive treatments is crucial.
Definitely food for thought. If you want to explore this more, you can look into the references from our source material, or, as always, talk to your own healthcare provider for personalized advice. Thank you for joining us for this deep dive.